Thank you for joining us this evening. My name is Kimberly Doris. I'm the Executive Director of the Graves' Disease and Thyroid Foundation. We'd like to thank the American Association of Endocrine Surgeons, or AAES, for co-hosting this event with us tonight. We are actually down one moderator due to a snowstorm and power outage, but we've got a great panel here for you tonight. If you have questions, please use the Q&A function instead of the chat or the raise hands. That will hopefully allow us to get through as many of your questions as possible. We had about 120 people registered for the event tonight. Our presenters are happy to answer general questions, but they're not able to give medical advice about your particular situation. And if we get through the night and we're not able to answer your question, please reach out to the GDATF and we'll try to get an answer for you. I'll drop our contact info in the chat, but we're at 877-643-3123 or email info@gdatf.org. AAES also has an excellent patient information page and a tool to help you find an experienced surgeon, and we'll drop that in the chat as well. And with that, I will turn things over to Dr. Lim for introductions.
Great, thank you, Kimberly. I'm Dr. James Lim, endocrine surgeon at Oregon Health and Science University. I'll be the primary moderator tonight. Unfortunately, one of our other moderators was unable to join due to weather conditions. I'd like to start off first by having our panelists introduce themselves from the beginning. Maybe we can start with Dr. Elizabeth Grubbs. I'll just go down with the line for me.
You got it. Hi, everyone. My name is Libby Grubbs. I'm an endocrine surgeon at MD Anderson Cancer Center in Houston, Texas.
Thank you. Next, Dr. Dawn Elfenbein.
Thanks, James. Yeah, I'm Dawn Elfenbein. I am also an endocrine surgeon, and I'm at the University of Wisconsin in Madison. That background is the lovely sunset that we have behind me in Madison.
Thank you. And next, Dr. Paul Ladenson.
I'm Paul Ladenson, an endocrinologist at Johns Hopkins in Baltimore.
Great, thank you. And Dr. Daniel Rootman.
I'm Dan Rootman. I'm an orbital ophthalmic plastic surgeon, and I work at UCLA. And happy to be here to be interloping into this endocrine symposium.
Great, no, appreciate having everyone, all our expert panelists joining us for today. I will echo Kimberly in that, if there are any other additional questions, you can also go to our websites for endocrine surgery. It's www.endocrinesurgery.org, and I believe that will be dropped into the drop-down chat where we have also Surgeon Finder as well as patient education pages as well. Let me start off first with Dr. Ladenson. What are the pros and cons to long-term use of thyroid hormone blockers such as methimazole? And I guess, comparing that to the other kind of definitive methods of radioactive iodine ablation or surgery, I guess, how do you present that to patients? Oh, Dr. Ladenson, I think you're muted.
Sorry. The anti-thyroid medications, methimazole and propylthiouracil, referred as you indicated, PTU, are medications that block the ability of the thyroid gland to make thyroid hormone. If a normal person took anti-thyroid drugs, it would give them an underactive thyroid. And for a patient with hyperthyroid Graves' disease, the aim is to normalize thyroid hormone levels in blood and tissues with the anti-thyroid drugs. These medications block the formation of new thyroid hormone. They do not, however, deal with the thyroid hormone that already exists in the enlarged thyroid of a patient with Graves' disease. And so one of their disadvantages is that it can take from 2 to 8 weeks after initiating anti-thyroid drug therapy to control hyperthyroidism. The anti-thyroid drugs have the advantage of not being a permanent treatment, not being a permanent treatment that's going to result in the short run in an underactive thyroid gland. And since most patients with Graves' disease are young or middle-aged and often are people who've never previously had a serious illness that wasn't going to blow over on its own, many patients are reluctant to take the leap for either of the permanent therapies. And I think for them, anti-thyroid drugs are attractive for that reason. Additional drawbacks of the anti-thyroid drugs are their adverse effects. 1 out of 20 patients taking anti-thyroid medication will develop a rash or itching, sometimes transient, but often not, and requiring discontinuation of the medicine. The anti-thyroid medications less frequently can cause arthritis, which again is transient, but can last weeks. And then in the realm of serious side effects, 2 out of 1,000 people taking the anti-thyroid drugs will lose their white blood cells, which protect us from infection, particularly bacterial infection. A very serious problem, potentially life-threatening problem, but fortunately very rare. And then finally, even less commonly, perhaps 1 out of 10,000 or 20,000 patients taking the anti-thyroid drugs can develop hepatitis. This is a greater risk with propylthiouracil. Usually it's manifest as blood tests showing liver abnormalities, but sometimes it can be a life-threatening form of liver failure. The biggest drawback of the anti-thyroid drugs is that they don't deal with the underlying autoimmune process that causes Graves' disease. And they're taken as a measure to control hyperthyroidism with the hope that the autoimmune disorder will go away. Most doctors use the anti-thyroid drugs with the intention of giving them for 6 to 12 months and then tapering them off to see how the underlying autoimmunity of Graves' disease is doing. For the majority of patients with hyperthyroid Graves' disease, after a year of treatment, that tapering off leads to a relapse. So the major drawback of the anti-thyroid drugs is that often they don't represent a permanent solution.
Great, thank you. And so once they relapse, or I guess at that point, is that when you consider or discuss the more definitive options of RAI or surgery? And so do you usually recommend a certain amount of medication treatment length before considering those definitive options?
Well, as a patient with hyperthyroid Graves' disease sits before me, I'm usually thinking you can take it now or you can take it later. Are you going to be a person who wants a definitive solution like radioiodine or surgery, which we'll be talking about, or are you someone who's not ready to make that decision yet and wants to control things and tread water to hope that a remission will occur? So
Great, thank you.
I discuss all three of the options, try and do so in an even-handed way. And then most patients would like the doctor to tell them what the doctor thinks is best. And I'm not shy about doing that.
Great, thank you. Dr. Grubbs, in terms of these definitive options, I guess, in your opinion, which patients are preferable to undergo surgery as opposed to other definitive options when you kind of see these patients?
Yeah, so, I echo Dr. Levinson that when a patient comes to me with Graves' disease, I also try to be very fair and balanced in helping them understand what the different options are. But you're right, there are certain times where I can certainly say to them, surgery seems to be the preferred option. Individuals that certainly come to mind, those that have Graves' ophthalmopathy, if they have moderate or severe eye disease, surgery is preferred over radioactive iodine ablation because it does have a less potential for acute worsening of that ophthalmopathy. The problem is that is not always obvious to non-ophthalmologists, including myself. And so one thing that I am very adamant about is that when patients come to me with Graves' disease, now sometimes it does hit me over the head. Even I can recognize severe Graves' ophthalmopathy, but sometimes I can't. And so I absolutely will partner with an ophthalmologist that is familiar with Graves' ophthalmopathy to have a baseline examination and give me their thoughts on whether they think this is moderate or severe disease, because in that setting, RAI is usually not the right answer, and we would say that surgery would be indicated there. Other things to think about, patients that come with large goiters, especially if they're already having compromised inspiration at baseline, sometimes there is the initial gland swelling potential with radioactive iodine, which could pose a problem and worsen already baseline issues. And that's obviously particularly worrisome with large goiters in which there's inspiration is already challenged. So those are ones. Individuals that have a desire to be pregnant within the short term are not good candidates usually for radioactive iodine, given the amount of time they need to wait before family planning. So surgery is often attractive to those individuals, or obviously patients who are pregnant and can't tolerate anti-thyroidal drugs, and maybe we'll get into which ones are appropriate during which times in pregnancy. But those are individuals that you would need to think about surgery for sure. Intolerance or side effects of the ATDs, Dr. Levinson talked about some of those, but those are things that force our hands to say that ATDs are not useful. And then I do work at a cancer center, so a lot of the reason we see these individuals are because they come to us in the setting as well of suspicious thyroid nodules on cytology or imaging, and those are folks that we certainly are going to say, radioactive iodine is not going to make those conditions go away. And so in this setting, we're serving two purposes in the form of treating your hyperthyroidism as well as your neoplasm. So those are ones that really come to mind, that we really are in the camp of surgery first.
Great, thank you. Dr. Elfenbein, I was hoping you could kind of go into some of the risks of thyroid surgery, and specifically kind of the risks that are, I guess, specific for Graves' disease patients, and kind of go into that a bit.
Yeah, sure. Thanks. Libby, I'm the same way. I go into patients' room and I kind of try to be as unbiased as possible. But the truth is I'm a surgeon. And so I see a lot of the advantages to surgery. I see a lot of people coming through and doing really well with surgery. But we do have a conversation before surgery that the risks of thyroidectomy and Graves' disease are higher than the risks of thyroidectomy for something like a benign thyroid nodule. Now, if someone has an advanced thyroid cancer that's invading into surrounding structures, that's probably the highest risk thyroid surgery. So Graves' disease risks are somewhere in the middle. All thyroid surgery has a risk to the recurrent laryngeal nerve, or the nerve that goes to your vocal cords. If we injure that nerve, it could leave you with a hoarse voice after surgery. There's some evidence that shows that perhaps that nerve is at a slightly higher risk in Graves' disease. The Graves' disease gland, especially in the very active inflammatory phase of Graves' disease, is large. It's very vascular. Sometimes the nerve is kind of pulled into the gland, and that overall risk is somewhere between 1% and 3% at sort of the low end, and can go even higher for some people, and that can be temporary or permanent. There's a risk for hypoparathyroidism. Now, parathyroid glands are these tiny glands that live near the thyroid gland that are at risk of getting damaged or devascularized during surgery. That risk we kind of overall quote somewhere around 2 to 10%, but in Graves' disease, I found that people who have low calcium after a thyroidectomy for Graves' disease, it can be as high as 30 or 40%. Graves' disease itself kind of messes with your body's ability to process calcium. And so it's kind of a double whammy for low calcium after surgery. Thankfully, that's also a temporary problem that you can help mitigate by giving patients calcium in the form of just Tums, a cheap and easy form of calcium, both before and after surgery, to try to reduce that risk. But that risk is certainly higher than in other types of thyroid disease. The risk of bleeding during this operation for Graves' disease is probably higher in Graves patients, but we're not talking about bleeding that, puts a patient at risk of dying or needing blood transfusions even. For a normal thyroid operation, or for a thyroid operation for something other than Graves, you might lose, a teaspoonful of blood, and for Graves, you might lose like a tablespoonful of blood. So it's still not a majorly, high bleeding surgery, but it's definitely higher for Graves' disease. And so those are the real major things that we talk about that are risks for thyroidectomy for Graves' disease. And we've looked into some ways to sort of decrease the inflammation and the blood flow to reduce those risks. But again, it's overall more risky than thyroidectomy for other operations, but certainly not, a hugely dangerous operation. I tell patients all the time, it's not brain surgery, it's not heart surgery, but it is a little more risky than other indications.
I guess just to follow up with that, are there any specific questions that patients should ask their surgeons about thyroid surgery or Graves' disease specifically, or?
Yeah, I think for any surgery, the question that I think lots of different subspecialties are encouraging patients to ask is, how many of these does your surgeon do, right? So thyroid surgery, especially when we're talking about thyroid surgery for something like Graves' disease, where the gland is large and inflamed, you really want someone who does a high volume of these surgeries. You're probably not going to want a Graves thyroidectomy to be done by someone who does, 2 or 3 thyroid surgeries a year. And does a whole bunch of other surgeries, but you want someone who's in someone's neck all the time doing thyroid and parathyroid operations. So you're really looking for a high volume surgeon, and surgeons should have a sense of what their own outcomes are for patients. So ask the surgeon for, not don't quote me the literature, tell me how many patients you have recurrent nerve injuries and hypoparathyroidism for. So knowing your own outcomes and knowing how many operations of this type you do a year are really important questions.
Great, thank you. Moving on to Dr. Rootman, I'm interested in this question specifically too, but for patients with Graves' eye disease, is there a time when thyroidectomy is preferable to radioactive iodine ablation? I feel like I say with any eye disease, thyroidectomy is preferred, but I guess what's the ophthalmologist's opinion?
Well, I mean, I first would say that I'm kind of on the opposite end of what Dr. Grubbs was talking about, is that I work quite closely with my endocrine colleagues, and I try not to wade into their territory. And so I feel like as an orbital surgeon, that there are, with the tools we have now, some newer medicines on the market, and the increased amount of knowledge that we have in this area, that we can pretty much deal with any type of eye disease. We could deal with any eye disease and any type of thyroid dysfunction or treatment plan. So if there is an indication for radioactive iodine thyroidectomy or avoiding both of those, we're going to be able to manage that. And we really leave it to the endocrine community to do what's best for the below the chin, we'll stay above the chin. You guys can be below the chin. And so, we can always deal with that. You're right. In the active stages of disease, there is enough literature out there to suggest that radioactive iodine can cause worsening of the eye disease. A lot of that literature is a bit older now, and particularly involves, very high levels of high numbers of smokers in those populations that they studied. And smoking is much less common now, at least, in California. If you smell a cigarette once a year, you're hanging out in the wrong places. It's really just not that common to see smokers anymore. And so that as a risk factor it's just changed over time. Now, of course, if you're in different places and there's a higher rate of smoking in those places, you might see that you're going to have those kind of really active, highly inflammatory kind of smokers with Graves' disease that may require active management beyond what they can get with anti-thyroid medicines. But for the most part, that's just not a population that we deal with that much anymore. On the medicine side, I'm actually, in general, I think the medicines are great, that they're pretty much neutral on the eye disease. If you can keep the patient euthyroid on medicines, then that's a great way to postpone things. You don't really have to make these decisions during the active phase of disease. You can kind of, ride it out until they're a little bit less inflammatory from an eye disease perspective, which is usually about a year and a half after onset of the eye disease, which usually is around the same time as the thyroid disease. So what you end up talking about is, what Dr. Lanninson was saying is kind of keeping them on the anti-thyroid medicine for about that first year. And that'll correspond pretty well with the eye disease kind of cooling down. And so if you're making those decisions about radioactive iodine or thyroidectomy kind of a year after onset, then you don't really have to worry about that kind of, inflammatory, really active, severe eye disease. And then you're making decisions based on what's best for the thyroid. If you're going to use radioactive iodine, we usually recommend using a short course of steroids around that time. And that can reduce the risk of worsening or new onset disease back to baseline. So if you are planning to use radioactive iodine, we do steroids around that time. I also agree that they should see an ophthalmologist around this time. I usually see them, right before, about a month before the radioactive iodine, and then about 2 or 3 weeks after, just to see how they're doing, see if things are worsening following the tapering course of steroids, just to see if there is any worsening. We can sometimes bump up that steroid. So, I really don't have a problem with radioactive iodine. If it's the right treatment for the patient, then we can deal with it from an eye disease perspective. The anti-thyroid medicines are pretty much neutral on the eye disease as long as the patient is maintained in a euthyroid state. And then thyroidectomy is a great option as well. And it's pretty much neutral on the eye disease. It doesn't really cause worsening of the eye disease, but it doesn't cure the eye disease. Which is often a misconception that's kind of that people have, is that if I take out the thyroid, that my eye disease is going to get better. It's not going to get worse if you take out your thyroid, but it's probably not going to get better. You really have to have a separate course of treatment for the eye disease. So, overall, I think all options are on the table. In the early stages of disease, the anti-thyroid medicines are probably better for a number of reasons. But if there is a requirement to move into definitive therapy early on, whether it's thyroidectomy or radioactive iodine, then we can deal with it using kind of our modern techniques, and some of the newer medicines are out there. So, I pretty much defer to the endocrine team and just manage whatever it is that they want to do.
Great, thank you for all that great information. That kind of leads me to the next point with Dr. Ladenson. Dr. Ladenson, what do you tell patients about the Graves' disease and the antibodies after a total thyroidectomy? Does anything change there, or I guess where does the disease go once you have your thyroid?
Well, after surgery or radioactive iodine therapy, typically the antibody markers of Graves' autoimmunity, thyroid stimulating immunoglobulins or thyroid hormone receptor binding antibodies, typically the level of those antibodies drops when there is no longer a target to incite the immune system's response. But, you know, the remaining elevation of those antibodies is really important in only one way, after the thyroid gland has either been removed or damaged by radioiodine. Those patients no longer have a target for the stimulating antibodies to provoke, causing hyperthyroidism. And that one special circumstance is the pregnant woman who, in whom the high level of those thyroid stimulating antibodies, whether it's during active Graves' disease or when Graves' disease is temporarily controlled with an anti-thyroid drug, or even after removal or ablation of the thyroid by surgery or radioiodine, those high antibodies can cross the placenta and cause Graves' disease in the fetus. So although the antibodies do typically decline after these ablative therapies, it's really not a very important issue for most patients. Those antibodies are not, as far as we know, the key immune responses that provoke the eye disease. Sometimes they run in parallel, often, but sometimes they have relatively independent courses. And patients who choose any of the three therapies, anti-thyroid drugs, radioiodine, surgery, any of them can still have an exacerbation of their eye disease. As others have pointed out, there is a 7% greater risk of that after radioiodine than surgery or continued anti-thyroid drugs. But I agree with the comments about glucocorticoid steroid coverage, which has been shown in high-quality prospective trials to completely negate the risks of exacerbating eye disease with radioiodine.
Great, thank you. Dr. Grubbs, how do the symptoms of Graves' disease change with treatment? And I guess to be more specific, you know, sometimes patients on long-term anti-thyroid medications still feel unwell, still feel the symptoms of hyperthyroidism. In your experience, have you found that these symptoms go away with a more definitive option, such as surgery or radioactive iodine?
Yes, so, you know, I think we all have our gestalt of treating patients, you know, especially as a surgeon with the modality of surgery, and knowing that in a lot of cases that is that definitive treatment does work. That has been backed up. You know, initially there have been in the past some smaller quality of life studies that have shown that, you know, after surgery there is really a rapid resolution of hyperthyroid symptoms, you know, within a month, you know, within a month period. And patients do have a lot of satisfaction that go with that. That being said, more recently, there have been some more robust quality of life studies, and a couple of these have come out of Sweden, in which they have looked at large numbers, you know, over 1,000 patients with Graves' disease, and compared them to normal populations, first of all. And what I will say is, when you have Graves' patients that are compared to kind of the quote unquote normal population that do not have Graves' disease, no matter what their treatment is, whether it's anti-thyroidal drugs, RAI, or surgery, compared to that population norm, these patients, even when they're 6 to 10 years out by, you know, some standard quality of life metrics, do have worse quality of life. So that is not, I think, a surprise to many of us, but there is data to show that they do still, even after treatment, have these changes. And these are in things like, eye symptoms, tiredness, cognitive complaints, different things that can be measured in that way. When you look just within the Graves population, and you're looking at different ways in which patients with Graves' disease are treated, when you're looking at anti-thyroidal drugs versus RAI versus surgery, it does show that in a number of instances that RAI patients 6 to 10 years after surgery in some of these studies do have worsening quality of life. And this is certainly seen in areas of goiter symptoms, hyperthyroidism symptoms, again, tiredness, cognitive complaints, anxiety, emotional susceptibility. And then if you look at some of the other more general, those are kind of thyroid specific quality of life measures. But if you look at more general quality of life measures, and we often use something called the SF-36, which is just kind of a general use of looking at patients' quality of life, it remains, right? General health, vitality, social function. Patients who were treated with radioactive iodine tend to report worse outcomes than those with anti-thyroidal drugs or surgery. So, these aren't perfect studies. We know that all quality of life can't be captured by one, looking at one survey, but we have really gotten some more robust data that tends to lean towards surgery and anti-thyroidal drugs for being better for more sustained quality of life control.
Great, thank you. Going back to the eyes, Dr. Rootman, for a patient with severe Graves' eye disease, what procedures are available for treatment? And kind of as a follow-up, do they benefit from definitive treatment of their thyroid before any of those eye procedures?
Yeah, I mean, it's actually a complicated question. Maybe you might have to do a fellowship in orbital surgery to get the answer to that. But well, from a thyroid perspective, I think it's pretty clear that as long as they're euthyroid, then the ophthalmologist is happy. So whatever needs to be done to make them euthyroid, they're all acceptable options from our perspective, and really have more to do with the balance of quality of life and the other factors that are going to determine whether definitive therapies or anti-thyroid medicines is right for that patient. But it is important that they are euthyroid. Large fluctuations in thyroid status can worsen the disease, fluctuating between hyper and hypo, over a period of time, rapidly over a period of time, has been associated with worsening eye disease. Additionally, if they are going to have definitive therapy, there's pretty good literature now. It's quite old, so it's pretty standard nowadays to begin the replacement therapy right away, not to wait. I think that there's pretty much, and most of my patients are after definitive therapy are on thyroid replacement within days. But it used to be a little bit longer, and there were some problems that occurred because of that. So from a thyroid perspective, as long as they're euthyroid, I think that that's neutral on the eye disease. And of course, any treatments are available to the patients. They're probably going to need to be euthyroid for any kind of surgical therapy, because it does create some surgical risk to be, to be hyper or hypo. And so we'd like to make sure everybody is euthyroid before they have surgery anyway. From an eye disease perspective, it's a bit of a complicated field, but you can generally think of it as there's kind of two stages of the disease where things are kind of changing near the beginning. That's that kind of first year, year and a half, maybe up to 2 years of symptoms. And during that phase, we really don't want to do too much surgery unless it's an emergency. And emergency surgery is very uncommon in this disease, less than 5%. So, that's not really that common to see. So for the most part, we don't do much surgery during that kind of phase. And then, so we use more medical therapies. And there's a lot of different medical therapies that are available. that each have kind of a niche for a certain thing that it's good at and other things that it's not good at. And so it's a little bit individualized as to what a patient is going to require, trying to balance the symptoms of their disease with the side effects of the medicines to find a point that's going to work for that patient. So that's kind of on the medical side, which I think we were going to talk about, some of the newer kind of breakthroughs that have occurred in the eye disease area a little later. The surgical treatment, once everything is settled down, again, it's also highly individualized. So you're always trying to balance the risks of the surgery versus the benefits that the patient can achieve. And so, finding that kind of sweet spot is going to be individualized for different patients, whether they have, a lot of eye bulging or a lot of eyelid dysfunction, double vision and eye movement disorders, whatever those may be, there's going to be a different combination of rehabilitative surgeries that we can offer for that patient. So, what I like to say, which I also agree with, is that with Dr. Grubbs, that you should see an ophthalmologist because, there's a lot more options on the table now than there were 20 or 30 years ago. And, for any patient, there's probably going to be something that we can do to help them with the eye disease. Now, not every patient wants anything and they feel fine, and that's completely fine. But if there is something there that is bothering patients, there are just a lot more options now. So we could find, the kind of tailored rehabilitative plan that works for them. So I guess that's kind of like the 10,000 foot view without getting into kind of the nitty gritty of each of the different kind of therapies. But I guess the substance of it is, as long as they're euthyroid, we're happy. And that there's a lot of different options, both medically and surgically, for patients to be able to kind of match a treatment plan to the things that are bothering them and the things that are important to them. So, it's always worthwhile to get that kind of consult from a thyroid eye disease specialist.
Great, thank you. No, I think that's also kind of a plug for these comprehensive teams where you have kind of specialists that are in a lot of different fields and can kind of cover the span of the symptoms that the patients may have. Dr. Laydenson, can you help us to demystify radioactive iodine ablation a little bit? And does it ever not work in Graves' disease patients? And, I think a question that's frequently asked, in terms of the risk of a secondary malignancy with radioactive iodine, I think, patients always like to know those questions.
Well, it's important for every patient to consider radioactive iodine, and there are very few patients in whom it is absolutely contraindicated. The one group that cannot, of course, take radioiodine are women who are currently pregnant. But others should hear about this option. In the United States, 20 years ago, 90% of patients with Graves' disease chose radioiodine therapy. And although its popularity has declined, mainly favoring long-term anti-thyroid drugs, still the vast majority of people who choose a permanent therapy end up choosing radioiodine. The origins of this treatment were more than 80 years ago now, when doctors began to use the newly synthesized radioisotopes of iodine to study the function of the thyroid, and then as early as the early 1940s begin to treat patients with hyperthyroidism with radioiodine. The treatment's a very simple one, an outpatient treatment where the patient swallows a capsule that is absorbed, and as blood flows through their thyroid gland, somewhere between a fourth and 90% of it will be trapped by the thyroid, which is then irradiated over the next 2 weeks or so. During that time, the vast majority of patients experience no side effects whatsoever. Perhaps 1 out of 10 people will have transient discomfort in the front of the neck, which can seem like an earache or a sore throat sometimes. The principal drawback of radioiodine therapy or drawbacks are, one, it takes 1 to 2 months for the radioiodine to work. And so patients really need to be well controlled with anti-thyroid drugs before treating them with radioiodine. And the same is true of surgery, of course. The other drawback to radioiodine is one that it shares with surgery, which is post-radioiodine hypothyroidism. So in answer to your question about, what's the likelihood of success, 3 out of 4 patients treated with radioiodine will be cured by a single dose. Among the remainder, 90% will be successfully treated with a second dose. In 40 years of treating patients with radioiodine, I've only had 2 that required more than 2 doses of radioactive iodine. I think the issue of secondary malignancies, it remains uncertain. Until the last decade, we had felt very confident that there was not a higher risk of secondary malignancies. Some recent studies have suggested a very low level of risk of certain secondary malignancies, in the neighborhood of 3 to 4 extra cancers out of 1,000 or 10,000 patient years. So I think we have to respect that uncertainty. The other issue I'd like to address that was brought up a moment ago is the patient with Graves' disease desirous of future pregnancy. And, kind of ironically, for those women, choosing one of the ablative therapies is usually the better choice, so that they will be prepared to move ahead building their family rather than going through another year of anti-thyroid drugs. We can use anti-thyroid drugs during pregnancy, but it's a dicey business that requires careful monitoring and dose adjustment. It's something neither the doctor nor the patient, wants to do. And at least in our clinic, when patients choose radioiodine, we simply want them to be stably euthyroid after treatment, which is usually 3 to 4 months later, and then they can move ahead with pregnancies. I think the widespread recommendation of waiting 6 months or a year just has no basis whatsoever.
Got it. Thank you. And in terms of, are there certain patients that would do best with radioactive iodine as opposed to, surgery? Is it kind of what Dr. Grubbs mentioned in terms of the larger thyroid nodules and those compressive symptoms that are not good candidates for radioactive iodine?
Well, let me maybe start by saying who, in my mind, really ought to be encouraged to have surgery. And I think those are patients who need a very prompt recovery. Somebody who's scheduled to leave on a mission in a remote place in 2 months, someone who wants to get pregnant in March, those are patients who will get better the fastest with surgery. There are the patients who have another reason to have neck surgery. Patients who also have a condition called hyperparathyroidism, which should always be thought of before patients make a decision. As was mentioned earlier, if patients have a thyroid nodule, a lump in the thyroid, and tests suggest it either is cancer or might well be cancer, those are all patients where you can kill two birds with one stone by having surgery. In terms of the issue of large thyroid glands of big goiters is, I think, controversial, but probably surgery is a better approach for those patients. In terms of patients who really should take radioiodine, they're the patients who are not good candidates for surgery that's going to require general anesthesia. And so older patients, individuals with heart or lung disease, coagulopathies, that is, disorders of blood clotting, those are all patients who I think should be steered toward radioiodine therapy.
Great, thank you. Dr. Elfenbein, in your practice, what medical treatment do you recommend prior to, in order to get patients ready for their thyroid surgery? Are there any certain parameters you make them meet before going to the operating room?
Yeah, thanks. And I've been kind of in between listening, typing some answers to patients that have been asking questions. And one of them was that, like, do I have to have normal thyroid function before going to the operating room? And the answer is really yes, or very close to normal thyroid function. We're never going to take someone to the operating room who's overtly hyperthyroid unless there's something truly kind of emergent going on. Dr. Layton did talk about the rare patient who comes in with no white blood cells and a terrible infection and they're septic in the ICU. Those are patients where we would do a really rapid prep and try to get them ready for the operating room. But in the vast majority of cases, we need patients to be on methimazole or PTU and mostly normal thyroid function before we go to the operating room. And the reason for that is doing general anesthesia in a person who has very high thyroid circulating hormone levels is at risk for something called thyroid storm, which is essentially a cardiovascular collapse, a problem with your heart and things like that during surgery. So we don't want that to happen. So that's first, getting you mostly normal thyroid function on methimazole or PTU before surgery. The second one is a medication called Lugol solution or iodine solution. Essentially the same iodine that you would, I'm a camper, so it's this iodine that you would use to kind of sterilize water if you're out camping. And what that does is it kind of floods the iodine receptors in the thyroid gland and really kind of decreases the vascularity, the blood vessels and the blood flow to your thyroid gland right before surgery. We'll give that for a short amount of time right before surgery. It's important to give it just in the 10 days before surgery and not longer than that because it acts on a very short-term basis. And then here at Wisconsin, we give patients Tums. I mentioned that earlier, to try to kind of beef up the calcium levels in your body before going to surgery to kind of reduce that risk of post-op hypocalcemia or low calcium levels. So that's it. Trying to normalize thyroid function, giving you some iodine solution to reduce the vascularity of the gland and make the gland hopefully a little easier to remove, and giving you Tums to reduce that post-op calcium risk after surgery.
Great. I guess I'm a surgeon, and Dr. Grubbs is also, I guess, thyroid surgeon specifically on the call. Dr. Grubbs, is that also kind of your parameters too? Anything else you would add to that?
No, definitely. I absolutely agree. I mean, there's data to show that, that making sure that patients' calcium and vitamin D prior to surgery does help prevent, hypocalcemia after surgery. And, as I always say to patients, you are absolutely lovely. Your Graves' thyroid is not. It is just the most hostile organ that you can imagine. And so anything that we can do to make that organ less hostile in the operating room is what we want to do. And one of those is certainly to try to get those parathyroids every opportunity to work appropriately and afterwards. And then there's the effect of just the Graves' disease with the calcium in bone. So I agree that, and also I was answering something in the chat, so sorry if Don said this, but we do like to, for heart rate, we do like to try to use beta blockade or rather for blood pressure to reduce that prior to surgery if possible. So we will often add a beta blockade prior to surgery.
Great, and then I think just last fall for that, I'm curious about the Lugol's and the SSKI. Is that something that 100% you always do with your patients, Dr. Grubbs and Dr. Elfenbein, or are you guys always able to get it through the pharmacy or any other? I guess, how does that work?
It's tough right now. There's a nationwide shortage, is what I've been told, and our pharmacy is especially compounding these little bottles of it for our patients right at our hospital. And we stopped using it for a while because I think that for a while it was a little unclear and people weren't really sure if it was making a difference. And then about 6 years ago, one of my partners up here did a randomized trial, and was kind of surprised that it really did seem to make a difference, even in patients that because right, I'll look at a patient, I'll say, this is a really vascular thyroid gland. They definitely need iodine solution. Then there's other Graves patients that it doesn't look so vascular. It kind of feels more firm. Maybe they're further into their Graves course, where I'll say you probably don't need the iodine solution. We can probably get by without it. But after that trial came out, I'm a bigger believer into if it's available, if it's not being, sometimes patients get told it's going to cost like $300 for iodine solution. I'm like, go to Amazon and just order it off of Amazon, like the stuff that you would get for camping. It's basically the same stuff. And so if it's available, I do encourage all of our patients to take it. It does taste disgusting though, so a lot of patients will take it for a day or two and then stop because it tastes bad.
We'll mix it in juice, but no, I agree with, I definitely agree with Don that if it's available, I use it, but it is not a game stopper. If you can't get it, it's okay. Right. I do think that the more important data really is, and we've talked a little bit about this, but what data does show in Graves' disease is if you have a high volume surgeon, someone that does these surgeries often, is much more important than Lugol's in terms of helping prevent some of these risks that Dr. Elfenbein is talking about.
Great, thank you. Dr. Rootman, I know we're kind of getting to the end of our time here. I was wondering, hopefully you could talk about one of these newer medications that is FDA approved for Graves' eye disease. I guess, can you talk about your experience with Tepezza, and I guess in a couple minutes, kind of what you see, who benefits the most, and if it's easy to get insurance coverage wise?
Yeah, I mean, Tepezza is actually it is a revolutionary disease in our drug in our field. It really is the first drug that has major effects on the bigger aspects of the thyroid eye disease that cause patients to have disability, and that is the kind of bulging of the eyes, the double vision, and decreased vision. And those things, it actually works pretty well on those things. The issue is that it has side effects, and the side effects are real, and they all occur. Most patients who take Tepezza do get side effects. Most of those patients who have side effects continue the course of the drug. And the reason why is because the side effects are relatively mild relative to the amount of benefit that they're getting from it. But they do get a lot of side effects, and there's a wide range of kind of weird stuff that you should really go over in detail with anybody who's going to be thinking about prescribing it. But that kind of balance, it does push you towards using the medicine in more severe cases of the disease. Because if you have relatively mild disease that could be treated, for instance, surgically with relatively safe and minimally invasive kind of outpatient surgeries, then that's probably an easier way to go for those kind of problems. Whereas, taking a medicine that has side effects. It's not always 100% effective. And it's extraordinarily expensive. When you only have like, mild amount of disease, the balance might not work out. So in general, we tend to, kind of offer Tepezza, or at least have a discussion about it with patients with that kind of like more moderate to severe types of disease. Those are people who have, restriction of the muscles, a lot of bulging, double vision, or other types of vision loss. Those are the kind of people that we're thinking about typically using that medicine for. The insurances don't like it because it's about the cost of a Skookum Ferrari, not like a regular Ferrari, like a nice Ferrari. Apparently, there's different levels of Ferraris, but they'll pay for it because it's FDA approved, and so there is a pathway to get that done. And I very rarely have patients that require it or that are eligible for it who aren't able to get it through insurance. Sometimes it takes a little longer. You have to do various appeals, but eventually it works out. So if it's right for you and you have insurance, then it's the type of thing that can happen for you, that we can make that happen. But of course, like all treatments, it has a balance of pluses and minuses. On the plus side, it can be quite effective. On the minus side, it has a lot of side effects, and it's not totally permanent for everybody. Some of the people who have improvement, in fact, a lot of people who have improvement will have some regression about 9 months after the drug, but still may be better than baseline in the end. One of the most exciting things about Tepezza reaching the market is that it's been a Harvard Business School case study, which has really made a lot of other Harvard Business School type of people be very interested in thyroid eye disease. And so now currently there's at least 6 or 7 clinical trials for newer medicines that are out there right now. And within the next 3 or 5 years, there's going to be, there'll be options. There'll be options on the table of different types of medicines that may be more appropriate for certain patients, with different types of side effect profiles. And some of these medicines may even have an effect on the thyroid function as well. So, stay tuned. I think that there's, it's an exciting field that's coming into the future. And for now, if Tepezza is right for you, then you shouldn't be afraid of it. But you do have to consider, all the, the risks and benefits of that medicine, just like any other treatment.
All right. Thank you. That is all the time that we have. Thank you so much to everybody that joined us tonight, to our panelists and our moderator. And we hope that our missing moderator who's caught in the snowstorm is okay. Again, if we did not get to your question tonight, please reach out to the GDATF. That contact info is in the chat. And we're fellow patients. We will not give medical advice, but we'll do our best to get you an answer. Thank you so much and have a wonderful evening. Take care.